Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you back to episode 175 of Limb Lengthening Live, where the patients interview the guests. And today, that's right, you are not seeing a ghost. We have the one, the only Dr. Craig Robbins from the Paley Institute. Welcome back, Dr. Robbins. How are you?
I am wonderful. It is so nice to be here. Victor and I were catching up pre-show, and I haven't seen him since his shows, and he hasn't seen me since this nonsense. So it's nice. I'm sorry we've been out of touch for so long. Our lives are just zigging and zagging, but we're back as we always come back together, and we have a good show planned, even though I have no idea what we're talking about.
That's what, I love it. Keep it a surprise.
Your audience, they're always prepared and ask me good questions.
They do. And today they're not going to disappoint. So before, I think it was yesterday, I put out the word that Dr. Robbins was coming on, and you guys delivered. You sent in your questions. So I'm going to go ahead and share my screen. We're going to take the first questions are going to be the case study. So let me just make sure he can see it. Let me just get over here. All right, Dr. Robbins, can you see that a little bit?
I sure can.
Okay, so this is a case study from a patient that recently sent it in. So I'll let you read the synopsis.
Okay.
So I'll read it out so that everybody can hear, because it's going to be an audio podcast as well. So it says, "Dear Dr. Robbins, I underwent tibial lengthening surgery on September 30th using the precise 2.2 nail. I began lengthening on day 10 and have been continuing lengthening at 0.75 millimeters per day. Immediately after surgery, I was able to move all my joints normally. However, about 2 days later, my left leg became swollen and I lost the ability to lift my foot upward. I was subsequently diagnosed with peroneal nerve neuropathy, foot drop, resulting in a loss of dorsiflexion and numbness and tingling along the front of the shin and the top of the foot. Question 1. Over the past 3 weeks, I've noticed gradual improvement, including the partial toe movement and ankle twitching, but I still can't lift the foot to 90 degrees, even while lying down. Can you please clarify whether this complication is preventable or an unavoidable surgical risk? Also, based on my recovery so far, do you think I am likely to make a full recovery of nerve function?"
Okay, so there's lots of questions. So, I'm going to answer the questions that were asked directly, but I'm also going to take license to generalize this to other people. So we're not just talking to one person, because there's always information that can be learned, especially if there's somebody having a less than optimal outcome or a complication or a problem or whatever we're going to call it. So first of all, the fact that, and I can only go by what you say, but the fact that you woke up and everything was moving normally and felt normally, and then you lost some sensation and motion, tells us that the nerve is in fact intact. There wasn't some strange problem where the nerve was cut, transected. Nothing catastrophic happened to the nerve. The nerve got stretched, which can happen with any lengthening. So a couple of questions. 1, are you still lengthening? If you are, you might want to stop. 2, if you were in our practice, you would be immediately, urgently having a peroneal nerve decompression. Personal history, we had a patient recently who had surgery elsewhere. They lengthened with different protocols than we use. This person developed a foot drop, communicated to us. We gave our recommendations, and 3 days later, he was in my clinic, and the next morning, he was in the operating room for a peroneal nerve decompression. Now, in the interim, while that patient was traveling, due to stopping lengthening, the nerve started to wake up, and that was good, but we did the nerve decompression just to help speed the recovery. So in general, we have had patients who have had developed weakness or numbness, and fortunately, they all recover. But we don't necessarily continue the lengthening. We don't necessarily continue at the same rate. Everyone's obviously different, because sometimes the bone is so well healing that if you slow down, it may consolidate, but length is never guaranteed. Length is never the priority. Function and return to function always are. So it's always a discussion to have. Your surgery, you're only 2 weeks from surgery, so the odds of you consolidating early are very low, but it's definitely a discussion with your surgeon to do a nerve decompression urgently. And if you're going to be in the operating room, you might as well do it on both sides. We would push hard for doing the other side, even if you're not having a problem. You also want to look and see, did the bone displace when they cut the fibula? Because sometimes the bone displacing can put traction on the nerve. So maybe you have to loosen some tissues there, and you may want to consider slowing down. So let's make sure we're answering your questions. Can I clarify? So, well, It doesn't sound like anything was done wrong because you woke up with nerve functioning. So it's just unfortunate that you either developed swelling or your nerves were just too bothered. Maybe you have some undiagnosed neuropathy underlying. You've had a back injury, you have a sciatic nerve injury, you've had subclinical nerve irritation, and then the nerve stretching of lengthening just exacerbated it. So there's lots of things we don't know about your past history, but if you stopped lengthening immediately, I would expect a full recovery sooner rather than later. But if you continue lengthening, the nerve has more length to recover. So we have had patients who had a toe drop, and even finishing lengthening, the toe drop wakes up, but it can take a couple of weeks or even a couple of months. Wow. So there's a lot in there. I'm a little concerned about the leg swelling, because when you talk about leg swelling, the emergency thing that comes to mind is something called compartment syndrome. Compartment syndrome generally involves excruciating pain as the first problem before it gets to weakness or numbness or things like that. Those are typically further down the line. If you had a compartment syndrome that's causing this, I think you would have known that, and you would have hopefully had emergency surgery to let the pressure out. So again, I'm not treating you. There's all those disclaimers, but in general, you need to have a conversation with your surgeon about the rate of your lengthening. Re-look through your history. Did you have underlying nerve problems before? Are you diabetic? Did you have a spinal problem with pinched nerves, and maybe this is exacerbating it? Hold on one second.
Sure. He's got a patient, guys. So everybody in the chat, put your questions in. We're doing the submitted questions first, and we'll take chat questions later.
Okay, I'm here. Okay, so these are definitely conversations for your surgeon, but a peroneal nerve decompression is very high on the list to be done. If you're having pain, you may want to talk about starting some sort of nerve type medication like gabapentin or Lyrica or something like that. But those don't undo the nerve irritation. They make the symptoms less, but you don't take a nerve pill if the nerve is being stretched too much. So I don't want you to think a pill is going to solve this problem. Okay, I think we answered those things.
Yeah, so, yeah. And I had a follow-up question for that. So like you said, compartment syndrome and or peroneal nerve compression, can both of those lead to drop foot?
Yes. Okay. So compartment syndrome can cause lots of problems. And without getting in too much detail, your listeners are smart and they all have access to Dr. Google, but the peroneal nerve has several branches. One branch makes the sensation on the shin and the top of the foot. One branch makes the ankle go up and the little toes go up and the big toe go up. And that's a branch of the nerve called the deep peroneal nerve that also has special sensation to the skin between the first and second toe. So a good clinical exam can kind of help you work backwards up the tree and decide where the nerve injury or the nerve irritation or the nerve compression is coming from. So yes, your nerve was intact when you woke up, it then lost function, and it is starting to improve. So yes, I expect things will recover. I can't tell you what rate, but lengthening at 3 turns per day would be low on my list of priorities right now. Nerve function always trumps height. So these are real discussions to have with your surgeon. A nerve decompression may aid recovery. And if you were one of my patients, you would have already had it by now.
Wow. Okay. All right. Moving along to the second question. In addition, I also have a protruding tibial screw on the left side, elevated about 1 centimeter under the skin. It's causing burning pain and irritation, especially when bending my knee. The screw is fully threaded and secures the upper tibia near the fibular head. I'm concerned this may represent hardware loosening and that it might eventually breach the skin. My doctor said that he's going to retighten the screw in the next visit, but I'm worried that it could loosen again or might re-engage properly in the bone. Could you please share your thoughts on it? Whether it would be safer to replace it with a shorter screw or remove it completely, screw it back, like my doctor suggests?
So one of two things happen. Either the screw has been in the same place it's always been and you just have less swelling, or you've lost weight and it's now more bothersome, or it really has loosened. If it really has loosened and backed up, then there's no reason that it can't continue to loosen and back up. But if it is a fully threaded screw, it is unlikely that it's loosened and backed up because there's threads along the whole length. The pegs that we use are only threaded about this much on the near cortex. they're not threaded the whole length for various reasons, getting into materials physics. A fully threaded screw is less strong than a peg because the core diameter is stronger substantially. So we use the threaded pegs. Anyway, that being said, you look at an old x-ray. Show me x-rays all along from the day of surgery to where you are now. If it's actually backed up, then yes, it may continue to back up. If it puts enough pressure on the skin, it can actually erode through the skin and create an ulcer. If it wasn't put in enough, sometimes that happens. Skin gets irritated. Sometimes in clinic, you can sterilize the area, make an incision, and actually tighten it in clinic. It's uncomfortable because you can't numb the bone, but you can numb the area. Yeah, I won't get into whether it should be in clinic or in the operating room. That's for you guys to discuss. But prove to me that it's actually loosened, and that's a different story than if it has always been that way and it just wasn't put in deep enough, or you've lost weight and now it's more bothersome and it wasn't in the first few weeks or months after surgery. Mm-hmm. So if there's a screw that actually loosened, you got to figure out why. Was it a technical error, the wrong size drill, the wrong screw was put in? There's always a bigger screw. So if the screw had a diameter of 3.5 or 4 millimeters through the same incision, through the same drill hole, you could put a slightly bigger screw and then that would stay in place. And so it's unfortunate. It's not catastrophic. The question becomes, though, if it's holding the tibia and fibula and you take the screw out, before you put the new screw in, what's going to keep the fibula from moving? So sometimes you'll put a temporary wire to hold the tibia and fibula in a different place. You'll take out the bad screw and you'll put in the new screw. So the way we say that is you add before you subtract, because if you take the screw out and it's under tension, the fibula could shift a little bit and then your holes don't line up. So it's not catastrophic. Prove to me that it's truly loosened versus has always been like that. And yes, it can be fixed.
Awesome. Wow. Wow. Technical guys. All right. Moving along to case study number 2. Sorry, I just got this one in, so I didn't format it properly. Okay. But he's saying he's 35 years old. He's 5'4", doing femurs for 7.5 centimeters and tibias for 5 centimeters 1 year apart, precise 2.
I love that plan. Love that plan.
Yep. Spacing them out. Soccer, ballet, gym 5 days a week, longevity, all that good stuff. Here's his first question. I have factor 7 deficiency, predisposition for thrombosis. According to my DNA test, would this disqualify me for the surgeries?
No, it would mean you need a very good letter from your hematologist with very specific recommendations for the anesthesiology team before, during, and after surgery. Very specific guidance on blood clot prevention after surgery. If there's any recommendations for certain medications or blood tests or for certain screening. And it would also make sure that you have access to a local hematologist. If you live in one city and your surgery is happening in another city and you're having a problem or a crisis, your original doctor may not be able to treat you across state lines or country lines. So these are elective surgeries. You have all the time in the world to plan. And if it takes an extra month or two, that's fine. Make sure you also have access to a hematologist in the place where you're going to live or be treated so they can help you too. So you got lots of time to make preparations. So by definition, are there disqualifying things? Yes, I don't think this is. If the hematologist says you're a stable candidate for the selective surgery, but they've probably not heard of it. And if you were my patient, I would talk to the hematologist and I would tell him or her exactly what's involved, and we'd decide a safe way to move forward. But this is not something you discuss on Monday and have surgery on Tuesday. You have all the time in the world to prepare. So take all the time in the world to prepare.
Makes sense. Makes sense.
Would I recommend surgery a week or apart? I don't know what risk we're trying to mitigate by doing that. You know, if the hematologist says, "Oh my gosh, there's literature to prove this treatment strategy," then sure. I doubt there is, because you're probably the one patient in the world who now has this and is having stature lengthening. So no, in general, we don't do one femur at a time.
Gotcha. All right. Second question. Given my knee issues, I'm wondering if I even qualify for femur lengthening or if it'll give me more problems in the future, like 10 years down the line. I have left knee patellar chondropathy, moving knee theater knee pain. I've never heard of that. That's interesting. My knee pain is about 1 out of 10 after watching a movie. or if I stay seated in that position. After walking about 3 minutes, the pain goes away. I also had a quadriceps tendinopathy 6 months ago on the same left knee, and now it's resolved with a lot of therapy. 10 years ago, I also had shin splints and Osgood Slatters, and
Yep.
it was painful to walk, 4 out of 10. Now those are all resolved. Given my above issues, would I qualify for the surgery? Will it bring back those old issues in the future, 10 years down the road?
Great question. So first of all, no one single thing or that constellation doesn't necessarily disqualify you. Going back to what we've discussed many, many times, there's no guarantee for length. The person in the room next to you may easily get to 7 or 8 centimeters. You may have a struggle bus to get to 3 centimeters. That's the lot in life. We will never guarantee anything. Is it possible to get 7 or 8 centimeters with these problems? Yes, of course it is. Is it possible you don't? Yes, of course it is. Lengthening is a decision every day, whether it's safe to continue, whether you're making it personally based on the way it looks to you or how you feel, and certainly with the guidance of the therapist you see a few times a week, and myself whenever you see me. So if you are getting to 3 and 4 centimeters and it's acting up the knee pain and it's acting up the tendinopathy and it's acting up all these things, the conversation may be to slow down or stop. Well, femur lengthening may consolidate if you slow down or stop. So you may only get to 3 or 4 centimeters. Eventually you stop, eventually you rehab, eventually things stretch out, and I expect you to get back to where you were. There's no reason you wouldn't. We've done plenty of patients who had ACL reconstructions, hip labral repairs, whatever the problem may be, and we don't even entertain doing elective surgery until you're back to your baseline or you feel like you're 100%, because any underlying problem will be exploited. For example, the first patient we talked about, maybe they had a little sciatica they forgot about. They sit on the toilet too long, they sit in a chair too long, they drive a car too long, and their leg goes numb, and that's a bothersome. But now you put traction on that nerve through lengthening, and now that bothersome thing is an actual real problematic functional thing. So lengthening, as Dr. Paley says all the time, is not to be taken lightly. It is a dangerous game. And any problem you have, your body will exploit. Your body will take the path of least resistance. And if flaring up your tendons and limiting your motion to decrease pain is making your body feel better, then it will do that. So the good news is you did rehab and it helped you. So you're not naive to rehab. You're not naive to pain. You're not naive to being treated for injury. So in that sense, you're psychologically more prepared than most people are. So I expect you're going to jump into your rehab very strongly. And I would expect that gives you an edge on people who haven't. So no, none of these things we're discussing disqualify you, but it's a very real conversation. I will never promise you a length. I just promise you I'll help you reach whatever length we think is safest. And it's a fluid conversation. This week may be great. Next week may be bad. Maybe we slow down for a few days, bump up the therapy, change what you're doing in therapy, do more heat and ice, do the bike, do the pool. There's lots of options. And we just kind of evaluate and we help you navigate what's the best way to get you where you want to be so that you fully recover. So it's a lot of words, but long story short, yes, I think you can do it. Just be very mindful. And pardon me 1 second, I'm just checking my phone.
Sure thing, sure thing.
I knew a patient was going to an emergency room somewhere with some problem. The emergency room happens to be not in my state. So
no.
Not like I can run in and go treat this patient. Make sure I'm not
You're super Robbins. You can be there in a flash.
Traffic, I caught alarm video. I spoke to the patient and the emergency room physician. They will keep me updated. Thank you. Okay. All right, I'm back.
All right. Real quick side tangent. Like you did a lot of miles. You were running a lot during the summer and the early spring. Did you ever get shin splints?
I have had shin splints maybe twice in my life by memory, and they were decades ago. I know they can be terrible. I've been very blessed. I've been fighting this stupid hamstring thing that it's not the stabbing pain like shin splints can be, but every step, my hamstring is like a little ice pick and it lets me know, and it limits my pace. It limits my distance. Like I haven't run in 3 months. I'm trying to just totally chill it. I ran 4 miles the other day and it kicked my butt. Like it just hurt. Yeah.
That's crazy. So, is it more distal or is it a proximal hamstring injury?
proximal. It's weird because it's not on the insertion.
Yeah.
It's not. I went and saw my physiatrist, and he's like, I don't know. We could put some PRP in it, or you can stop running. You know, that's the easy answer. I don't know. Holly, my wife, is a PT. She tries to do the Indiba machine every night. She wants to treat me every night, but I won't let her treat me. She's exhausted at the end of the day. I'm not her problem.
Right. That's great. Have you tried the massage gun?
I do. I put the massage gun on it. I can, if I move in a very specific spot, I can feel where it is. Yeah. So if I had a needle, I could stick a needle in it. I thought about dry needling and all these, but Victor, man, I'm 10th on the list. There's 100 of importance before me. Kids first, family, whatever. Eventually I'll get around to taking care of me.
And his massive Halloween party at the end, which we're going to talk about.
Right. Yeah. I guess we were offline. Right. We have our big Halloween party tomorrow. So I got 20 pounds of pork, just came off the smoker. I had 6 rack of ribs cycling through the smoker in the oven right now. I'm decorating, you know.
It probably smells wonderful in the Robbins household. I'm going to be down there tomorrow, so don't worry.
I got my son is playing in a big giant football game on Saturday.
All his buddies are going to come over. Yeah, we'll talk about it at the end. All right, guys, back into it. So this segment is the submitted questions. So basically, these are the ones that were sent in besides the case study. So this one's about a bone canal. So if the femur bone canal is enlarged by reaming to insert a larger nail, once the bone consolidates and the nail is successfully removed, will the thinned out bone cortices grow back and become thick like before, or is it reamed out, or is the reamed out bone permanently gone?
Well, I can tell you from personal experience, the reamed out bone does come back, but there's a lot more to this question. It's dependent on age, it's dependent on your bone density, it's dependent on your activity, it's dependent on where the bone is cut and how much is reamed. So the answer is yes, 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 no, no, yes, yes. It's all over the place. So Dr. Paley and I do a pretty good job. I can look at an x-ray, and I'm even getting to the point now where I can look at an x-ray that's a JPEG picture of a bad image held up to a backlight with no scale, and I can eyeball it and say, yeah, that's a 10.7, 95% of the chance. So I'm getting pretty good like that. But a lot of factors go into choosing the nail size. Sometimes we can just nail it, pun intended, preoperative. You got a giant canal, you're getting the largest nail that Precise has in its inventory, done deal, no problem, not worried about that. Most of the time, it's not like that. If your bone is very wide, it's usually very long. If your bone is very long, then you're probably not having stature surgery. So very few patients, 5 to 10%, maybe it's a little bit more, are getting the largest diameter nail. Now, we don't remove bone to put a larger nail if we don't think it's safe. And how do we know that? That gets to your second question. How much cortical bone do you really need to have left? And there's no one who's going to hollow 10 people to 1 millimeter, 10 millimeter to 20 people, and let them go run and see who breaks. It doesn't work that way. So no bones are perfectly round. Typically, the femur bone is narrower from side to side, and it's much thicker front to back. And because the femur has a very gentle bow, it's way thicker in the back where the big muscles attach. It's called the linea aspera. And when you're drilling through the femur front to back, much thicker in the back. So when you thin it out, it's not thinning it out symmetrically. So there's art to it. There's science to it. We do consider the inner diameter and the outer diameter, but we won't remove more bone than we think is safe. And different patients, it's a different answer to that. Also, when you're doing the surgery, when you're reaming, the anesthesiologist is giving us continuous feedback if your body is responding to the reaming, the fat, the bone marrow getting filtered through the lungs. Let's be clear, there are always fat embolism when you break a bone or you ream a bone. Fat embolism does not mean fat embolism syndrome. Fat embolism does not turn into fat embolism syndrome. If I was doing any orthopedic surgery, not stature surgery, you broke a bone and I'm putting a rod, and you're having a hip replaced, you're having a knee replaced. Anytime the intramedullary canal is being pressurized by my finger, by cement, by a total joint, the bone marrow is being released to your blood system. That's what your blood system does. The blood first goes to the veins, and then it goes through the heart, and then it goes to the lungs. So that's why the lungs get the problem. So there's always fat embolism. If I put an ultrasound and watched your heart while we're reaming, you're going to see fat going through the heart. That in itself is happening. That doesn't mean you're getting fat embolism syndrome. But at what point is it too much fat? Well, it's not just a volume thing. What's your underlying lung function? What's the rate at which you're reaming? Are you getting enough fluids? Are they giving albumin? There's so many things that go into it. It ultimately ends up to being a very specific implant. You are getting this size implant. And probably 70 to 90% of the time, I can guess what that implant's going to be before surgery. Sometimes the bone allows reaming easier than we expected, and we can upsize, and that's great and wonderful, because that may help you be able to stand unassisted, or whatever reason. In general, we think a larger diameter rod is better, just because it's stronger. But so inner canal matters. They both matter, inner and outer. If you have a 30 millimeter wide femur and a 8 millimeter wide canal, that doesn't mean I can arbitrarily ream you to 20 millimeters and give you a few millimeter rim, because that's removing a lot of bone. So anyway, I spoke a lot. They both matter, but sometimes a decision isn't made until surgery itself. And I can't speak to other institutes. We have a lot of nail sizes and a lot of nail options. So we're never forced by lack of inventory to upsize you to a nail that might not be safe just because that's all we have. I don't know if other institutes have that problem, but we have all the nails we need before surgery. So we may anticipate you need this size, but we also have larger and smaller sizes available, because we don't want to do anything unsafe just because our hand is forced by a not important factor, like not having the right nail.
Yeah. And can you tell the listeners, like, what are some of the risks of not having the right nail size or fitting too big of a nail in a canal that's too small?
If you have a giant bone and a little small nail, then the bone is swimming in the nail, and you can get some malalignment. If you have a giant bone and a small nail, then the nail may be more prone to breaking or bending. Just like we talked about a screw versus a peg is smooth all the way around. The diameter is from top to bottom, and the radius is half. The bending strength of a rod, of a cylinder, of a peg, is the radius to the fourth power. That's a lot. 2 times 2 times 2 times 2 is a lot. Imagine if I have a screw with a radius of 2, but the threads are part of that. So the core is actually narrower. It's maybe 1.5. So what's the difference of 1.5 times 1.5 times 1.5 times 1.5 is a lot less than 2 times 2. Anyway, so in general, a larger rod is better because it's stronger, better to resist bending, which we've talked about bending. I don't mind bending, but better to resist bending, better to resist rotation. It's just a stronger implant. It can bear more weight. So, and then what if you only have one size nail? You don't have a smaller one. You remove more bone, and now you've removed down to 2 or 3 or some arbitrarily small number of millimeters. Now the rod's going to come out, and maybe they're at risk for fracture. So maybe now you have to put a different rod in its place to prevent fracture. And that happens too. I had a conversation with a patient today who had very delayed healing of their tibias. We removed their lengthening rods and put in trauma rods. Trauma rods are very strong. So they supported the bone while he healed, but now the bone isn't making nice, beautiful, fluffy bone. It's a little bit narrow because the rod itself takes weight. So now I'm saying to him, we can leave the rod. You have enough healing now, but we'll take the screws out. And now every time you take a step, the bone is getting full force. The screws aren't sharing the load. The rod did its job to support it while it healed enough. Now we can take the screws out, leave the rod to prevent against a catastrophic fracture, and your bone will respond to the force by making more bone. So that's a lot of information.
No, so, there's always the trick of the trade that can get you to the end result safely. I love it. That's why this guy's one of the best guys. So that's why we bring him on.
I guess the question for your surgeon is, do you have nail size options? You know, what if I need a smaller rod than you think? Do you have it? So,
yeah, okay. That's true. All right. This one's about embolism. Yeah, so he's saying, can limb lengthening surgery cause vision loss due to retinal occlusion from the embolism or ischemic optic neuropathy?
So I've never been involved in a case where someone lost vision for whatever reason, whether it's ischemia or whatever. I've never been involved in a case that's had that. That being said, I have been in hospitals where that has happened. And gosh, if I've been doing this since medical school was, I don't even remember when medical school, 96, so 30 something years, the two cases that come to mind were patients having spine surgery. And I think it was very prolonged spine surgery in very, very sick patients. And again, I may be misremembering this, and I'm not trying to misrepresent. And I think the real cause is from low blood pressure causing the problem. So is it possible to get an occluded retina from an embolism? Not that I've ever heard of or read of. We talk about fat embolism affecting the lungs, but it would have to go through the lungs, through the heart, and then get to your eyeball to be embolic. So I don't think so. I've never heard of it. I've never heard of anybody having a traditional axial bone surgery getting either of those things. Remember, cosmetic stature surgery is a very small part of all the surgeries that I'm involved in or my hospital is involved in. There may be 50 or 100 non-stature bone surgeries done at our institute for every one stature surgery, and I'm not hearing about these things.
Gotcha. All right. Well, that's good news. All right. This one is about preparing for surgery. So I was wondering if a patient has already optimized their flexibility, their muscle development, their neuromuscular balance, potentially even reaching mild overstretching in some areas. Could that help shorten the post-surgery rehabilitation period needed to regain full athletic performance after leg lengthening? And if so, by what percent? Does it help the recovery timeline? More broadly, what can you do before surgery to minimize recovery time to get back to full recovery, essentially?
So yes, can it help? Minimally. And here's my answer. I'll use me as an example. I was up to the point where I was running 25 miles per week. I have this fancy watch that tracks my VO2 and it tells me all these parameters. And as long as I was running, all my numbers were good. But I stopped for my hamstring. 2 months later, 3 months later, I went for a run and I tanked. It kicked my booty. So let's say you spend 6 months stretching, you can do splits, you can do all the things. You have surgery, you're sore for a couple of days, you're in bed for a couple of days. Maybe you just don't want to do much therapy for the first week or two. Well, in that 2 weeks, you've lost a lot of what you've gained. And then you start lengthening and then you're sore. So what I tell my patients is, I don't expect your flexibility, muscle development, balance, or whatever your parameters are to be that much different, even if you really dive in for months and months. Why do I say that? Because you're coming to us as a normal person. You're not coming to us as an injured athlete. So if you can normally get on a bike, run up and down stairs, do your everyday thing, how much better can you be at that? You may be a little more flexible. The benefit isn't that you're that you're more flexible. The benefit is that your body is used to being stretched. Imagine, Victor, you haven't worked out for 6 months or a year and you don't even have to have a heavy leg day. You have a hard leg day where you may be bar only doing 50 sets of 50. You're not going to be able to walk for a week.
Yeah.
And it's not the weight that killed you. It's that the mitochondria aren't used to it. Your lactic acid, you don't have the clearing mechanisms. So the stretching and all the things you're doing makes your brain and body tuned to be stretched and respond. So I don't think your surgery will be any less challenging or difficult, but you're primed and ready to be a rehab candidate. So when they say, hey, get up, we're going to stretch you, you're already used to it and you're going to be much less sore because you're used to being stretched. So I tell my patients, it's not going to negate the IT band release. It's not going to negate the hamstring recession. It's not going to negate whatever we're doing, but you're used to being stretched. That's one less area of discomfort you're going to have after we do this very traumatic surgery. It's minimally invasive. It's little baby incisions, but we're breaking your bone in half. We're hollowing your bone. We're releasing these metabolites from surgery. And then we're laying you in bed for a couple of days, even though the therapists are coming around. So it's a lot of things happening to your body. So being prepared gets you mentally prepared, gets you physically prepared, gets you psychologically prepared, gets you emotionally prepared. So I can't tell you a percentage. What can someone do before surgery? Everything you're saying. If you have the good habits before, then you're going to continue the good habits. So my patients who do the hardest work after surgery are going to recover the fastest. You're not going to make your bone faster, but you'll get your muscle strength back. You'll get your endurance back. You're walking in a swimming pool. You're on a stationary bike. While your bone is waiting to heal, you're doing all of your stretching. So by the time the bone is healed, your body's ready to get up and walk. So if you had to pick 100 units of time dedicated to rehab, I would probably do 10 or 15 before and 85 during and after. I'm making those numbers up, but you get the point I'm getting at.
Absolutely. No, that's fair. And I agree with you. I actually found literature on saying that stretching, you have to kind of keep doing it to retain the results. Like you said, if you take off 2 weeks, you lose a lot, right? You have to do it up almost to the point, and then right afterwards, pick up with the PT immediately, or so you lose a tremendous amount. You're right. So literature backs you up.
You lose it fast. It takes a lot. Victor can tell you he's just been training his tushy off for months, for a year, for over a year.
Yep.
And you stop and it goes away quick, and your brain changes. Like you feed on the adrenaline and you feed on the schedule and you feed on everything. But once those patterns are broken, your brain fights you to get back.
Absolutely. And that happened right after the contest. Like I literally took off, like I did a deload week, like for a few days. And then I went back to working out the next week. You're right. I was incredibly sore in places that I never thought I would be sore ever again. So everything you're saying is literally like proven by anecdotally and literally.
I realize the sun is setting and I'm really dark here. Let me try to turn on the light.
Yeah. All right. Okay. So we're going to move on to the next one. Okay. So he's asking, could foot platform size place an upper limit on how much lengthening is achievable?
I don't know what that means. Could foot platform?
I guess.
Does that mean if you have a small foot, does that limit how much lengthening you can get?
I guess that's what it means.
All right, well, let's talk through this. So we've talked about reasons why femur lengthening is easier than tibia lengthening, and it's many reasons. One, because it's just one bone. Let me rephrase. It's not easier. Well, maybe it is easier. Why femur lengthening can get more length. Let's take it that way. It's one bone instead of two. The bone is surrounded by muscle. And it's easier to rehab. Why is it easier to rehab for femur lengthening than for tibia lengthening? Because if I'm rehabbing my femur, I have the whole length of my leg as a wrench, as a lever arm to bend and straighten my knee. If I'm rehabbing my tibia, I have the length of my foot as the wrench or the lever arm to work on stretching my calf. So yes, in theory, a shorter foot means you have a shorter wrench handle to get lever arm, but a therapist is going to be able to overcome that. A good therapist can be overcome that. If you had an amputation and you only had the back of your heel, well, then going into Aquinas wouldn't make much of a difference. That's a different story. We're going down a strange road. So no, I don't think I've ever had somebody whose lengthening was limited by the size of their foot. I can't think of a direct correlation. It's a really interesting question.
It is. I get that a lot. You'd be surprised.
Can you hear my son bouncing a ball on the door?
I do hear him. Is that Oliver?
No, that's Aaron. Hey, Aaron.
Now we're gonna put him on live stream. That's gonna be great. That's his punishment.
Okay.
We should make him answer a question for doing that. So I'm just kidding.
Yeah, right. You wanted to come on?
Yeah, bring him on.
Hey, Aaron. They have a question for you. Come here. What up, dog? Okay, we talk normal. Here, sit. This is Victor. Victor's live streaming.
What's up, Victor?
What's up, Era? How are you? Era, right?
Era, yeah.
Era. So say hi to the whole world of limb lengthening. Your dad's a superstar in this world.
Limb lengthening?
So, Era, I have two questions for you. How tall are you?
5'9".
5'9". And you got a big game coming up. What's going to be the?
That's all of them.
That's my other.
Oh, okay. Sorry. So, what were you bouncing? Basketball?
What did I play?
What were you bouncing? Was it the basketball?
A tennis, a fake ball and a tennis racket off the wall.
Oh, okay. Okay, gotcha. What are you going to be for Halloween? That's my other question.
See, I'm not the biggest fan of holidays and all those celebratory things, so I'm not going to do anything.
He's really not coming to the party because he's going to watch his brother play football.
Yeah.
Oh, okay.
I don't like Halloween, Christmas, 4th of July. I don't do any of that.
You don't do any of that. Oh, well, how can you be part of the Robbins household? I'm just kidding. Yeah. All right, you're out of here, Era. Get out of here. I'm just playing. No, it was great seeing you, man. All right,
nice meeting you guys.
Yeah, he flies out with one of my other sons and Oliver's mom. So they're all going to go watch his game, which is cool.
And that's Saturday?
This is Saturday. Missouri's playing Vanderbilt. Giant game.
Oh
Yeah,
man, that's gonna be huge. I'm gonna try to catch some of that. That's gonna be good. And Oliver's the kicker, right?
Oliver is the kicker. Maybe
Very
he'll be
cool.
doing goals. Who knows? Stop bouncing the ball.
He probably forgot. Oh man. All right. Next question is about arm lengthening. Can you just give a quick overview? Like, how does it work? What's the typical lengthening amount, and like some of the risks that go along with it?
Okay, arm lengthening, overview, lengthening amounts. So any surgery has potential risks: scar, infection, bleeding, pain, nerve injuries, contraction, whatever. The list is exhaustive. We know this. Arm lengthening is like leg lengthening in that the bone is bolted to the rod lengthens, you must do rehab. But there are significant differences between arm lengthening and leg lengthening. First difference is with arm lengthening, in general, we let you do remotely. What? Eyes widen? What are you saying? So in general, the protocol is you come in, we have our visits, we meet you, you have your surgery, and you stay local for 3 or 4 weeks. The first week is just kind of recovering from surgery. We lengthen 1 week later. We start our lengthening. You stay local for several weeks, make sure you understand the process, you know how to do your exercises, and then you're allowed to go home. But you're only allowed to do this if you can come in if there's an emergency. You can't go to another country. And here's Marshall. And in general, we have a video visit every 2 weeks with x-rays. And then we have an in-person visit every 4 weeks. So it lets you go home.
I've missed you, Marshall.
It lets you go home and then see me monthly. So you stay for basically a month. You go home. You're doing your lengthening from home, and I see you 1 month later, I see you 1 month later, and then you're done. The rods that will fit in most people are the same precise rod. It's the 8-centimeter rod. The amount of length you get is kind of a function of what you're trying to do, but by and large, it is a 5-centimeter lengthening. I can't think of a cosmetic arm lengthening we've done that was more than 5 centimeters. Just like with the legs, we talk about proportions. The potential risks in some sense go up with the amount of length, the risk of contracture or nerve injury, delayed healing, slow healing. So in our institute, if you're doing an arm lengthening, it would be after a femur lengthening. In general, I don't think we've had anyone do it after a tibia lengthening or femur quadrilateral lengthening, and it's for 5 centimeters, which is 2 inches. The surgery is by report less painful. It may only be 1 night in the hospital. We do both arms at the same time. You get sore at your shoulder because it goes through the top of your shoulder. There are potential risks as with everything, but there's more nerves at risk with arm lengthening, humerus lengthening than with any other, because the way the arm is, there's the axillary nerve on the side of the shoulder that could be injured. There's the radial nerve on the side of the arm that goes to the hand. There's the median nerve on the inside of, in the front of the elbow. There's the ulnar nerve. So every major nerve is potentially at risk just because the anatomy is different for the arm than the other limbs. So being with an experienced surgeon can help minimize those risks. So that's the overview. So it's up to 2 inches. In general, we lengthen at 1 millimeter per day. So that's about 60 days, 7-day latency, then 50 days of lengthening. You stay for several weeks to a month, you go home, you come back a month later, and then you're almost done lengthening.
Wow. Do you see pretty good bone healing with arm lengthening, since it's like
so everybody's different. I've seen very fast healing. I've seen very slow healing. We may start at 1 millimeter. We may start at 3/4 of a millimeter. A benefit or one potential benefit of arm lengthening is that you're not constrained to being wherever the treatment is for more than a month, hopefully. So what's the difference if it takes you 70 days to get the length instead of 50 days to get the length? Might as well go slower. Easier rehab, less chance of nerve being stretched. You're home anyway. Maybe it means 1 more extra visit for follow-up. So all these things are part of the conversation. It's age dependent. Have you had other surgery? How's your healing? But the x-rays every 2 weeks, that's why even though you're from home, we're getting x-rays every 2 weeks so we can assess how your bone is. I actually ask you to move. How does your elbow move? Bend and straighten for me. And we do all these things just like I'm seeing you in person. How are the nerves functioning? Yeah, we check that. So that's arm lengthening.
Wow. Yeah, I've been getting questions like that for months, and I was like, Dr. Robbins will be back to answer it. All right. This next one is about EMS, which is electric muscle stimulator, or a TENS unit, or it's a transcutaneous electrical nerve stimulator. And they're just asking, like, how can they use this as a treatment modality to help with like pain or muscle stimulation during lengthening?
So most patients don't. We have a really educated, really smart, really experienced rehab team. And some of the patients use these things either during treatment or at home. I'm not against any of them. And again, another benefit of coming to Paley Institute is you have the best therapists in the world. People are like, oh, Dr. Robbins, you did so great. You and Dr. Paley, all these things. And we're the first to say, we may be the face of this, or we may be the tip of the spear, or however you decide it, but we're only as good as we are is because we have the most excellent team behind us. Shout out to Angelique and Lena, the whole rehab team, all of our admins, you know, all the happy hugs all around. But it's really true. If I'm seeing you every 2 weeks in general, you're seeing the therapist 10 times between those visits. Certainly if there's an issue, you come see me immediately. I'm not going to make you wait 8 days if you've been having a problem. Another benefit of coming to Paley Institute is we're always available. But our therapists know all of these things, and they may say, hey, you may benefit from this. Let's try this. And they have a unit and they do it in clinic and they see how you feel. So I'm all for it. I'm not against it.
Awesome. And basically it doesn't have any type of like risk because of the electric stimulation.
Okay. Great question. No. So it would have to be a really strong magnet to have any bad effect.
Okay. Got it.
It's not going to damage.
All right. This next one is about how can you fly? Like, let's say that person did get arm lengthening and they have the ERC and they have to get on the airplane, and also blood thinners, like in compression socks, if you're going on an airplane. So do you have any tips for patients that are flying?
So if you don't have, so I'm speaking more to the US because we actually just had an interesting thing. We had a patient who took their ERC home to a foreign country. And if you don't have one in your case, there is a return FedEx shipping slip, but it was for domestic, not international. So the Globus people are just emailing them a return label with an international thing. So that's very easy. So we have access to, and I lose it all the time, but my reps get it for me. There is a printed letter and it says things like this has been proven, it's FAA compliant. And I don't remember if it says you can carry it on or you have to check it. I believe you probably have to check it, but people fly with them all the time. So ask your rep. I hate to dump this on Angelique, but you can send Angelique. Obviously, we're not going to do this if you're not our patient because we don't know you. But if you're one of our patients, have an issue, ask Angelique, and we can ask one of our reps to get you this letter if you need it. Blood thinners and compression socks, great topic because I say it all the time. I just traveled international to the Abu Dhabi clinic. We'll talk about that. I traveled international to the Poland, to the Warsaw clinic. Oh. I take aspirin for 2 days before I fly international, and I wear compression socks, and I get up and move because I do not want to get a blood clot. I don't have risk factors that I know of, but it's preventable, and why not? So today, let's see if I can pull this up. So here, so you don't think I'm searching for it right now. The conversation I had, my friend is very good at finding cool things on the internet. So today I sent her this message. See if this shows up. That show up. That's a purple compression sock.
Oh wow! Okay. Yeah.
And the message was, let me find. I can scroll up to the message. I want to order a large supply of purple compression socks of various sizes for my patients. I'm guessing there's a website I can do this. Any recommendations? And I asked my friends, and one of them wrote back and said, talk to my wife. She knows everything. So today, 2 hours ago, I was having this conversation about just getting a bunch of Paley compression socks. Welcome to the Paley Institute. Here's a pair of compression socks, enjoy. So just one more thing. It's just funny you ask that. So yeah, I'm a fan of compression socks.
I actually use them because I was doing a lot of cardio for my contest prep, and I would put them on. I would elevate my legs, and then I put them on, and it just helped the pressure. Just like it just felt better, right? Like it just incredibly. I took it up after you. You gave that tip last year. You're like, I run a lot, and I use compression socks, so it really does work.
I don't run in compression socks. I've never done that.
No.
I have to give a complete shout out to one of our amazing physician assistants, Erica Bullock. Boliek, Erica, Erica. She's all over social media. She does amazing stuff with the hormone replacement and growth, and go search her on TikTok and all of these things. She has great content on training and diet and all this stuff. Years ago, she's like, why don't you wear compression socks? Why do you wear compression socks? And I finally started wearing compression socks, and I still do. The trick is exactly what you said. You put them on either early in the day, or you put your legs up to get all the swelling out. Then you put them on. If you put them on after your legs are swollen, it doesn't really help you much. No. You're putting them on to prevent the swelling, not treat the swelling. I just got a bunch of pairs from my dad. I think we talked about this. I sent him a bunch of pairs because he walks a lot and he's getting leg swelling. There are some people wear them when they run, but the ones I wear are pretty high compression. I don't know how I'd feel wearing them for running. I don't know.
I wore some around the shin just to prevent shin splints, but I never wore them on my foot, you know.
People do that. The running ones tend to be from ankle to knee. They're like half compression socks.
Right. Look at Marshall. Look at that. We missed our mascot for Cyborg for Life live streams for this last 5 months. Like, Marshall, how have you been?
I tried to walk him twice. He just ate, so now he's ready to go. But that's okay.
Ready to go. Okay. Yeah, we probably have like about 20 minutes left. Let's chop this. All right. So next question here. Can you go through the post-lengthening surgery discharge process for new patients who are considering lengthening but worried about pain right after surgery? So like, how is the anesthesia work, the nerve block work? How does it all work?
Sure. Okay, so not everybody gets blocks in general. And I'm oversimplifying. In general, we don't do blocks for surgery below the knee. So for like tibia lengthening, we don't do blocks because there's potential for worse problems, compartment syndrome, nerve problems, and we'd like to know that, and the block can mask that. Like, this is going to be painful. It's not pain-free. There's no medications we can give you to induce a coma and make it pain-free and let you still walk, function, and get up and move. It doesn't work that way. It is uncomfortable. Expect there's going to be pain. Get used to working out. Get used to running, stretching, all the things we've talked about every time, and we've talked about more today. Get used to working your muscles till they're so sore it hurts to walk for a few days, and then you'll get a taste of what your muscle soreness can do. Now imagine we're going to break the bone surgically, open the bone with reaming, and then put a metal rod in, and that has its own level of discomfort associated with it. So if you're used to pain and getting over being sore, that gets you in a very good headspace. And it's good for you. It gets your heart going. It increases your metabolic rate. It helps get weight off. It helps get your body lean. So we don't say that just gratuitously. It's good to get up and move for everything. So whether it's a nerve block or an epidural or a collar, whatever type of anesthesia that might be peripheral, like an injection or something, or numbing medicine, then we use very powerful medications in the hospital for a few days. It includes anti-inflammatories. It includes Tylenol or paracetamol, whether that's a pill or an IV injection, and includes some use of narcotics. I'm not afraid to use narcotics in the perioperative period. We're not writing prescriptions for weeks and months at a time. So there are people who are legitimately concerned about becoming addicted. We're not giving you narcotics without good reason. We give them if you need them to manage the pain, but then you get off of them because the pain goes down, the pain goes away. But if you are mentally prepared to have a certain level of discomfort and pain, that's a good thing because it's going to hurt and sore. Nothing in life comes easy. Ask Victor how many sets he did to failure, how many times he puked and then got up and finished his sets and puked again, or almost passed out. And that's not like once or twice. That was like for the last 14 months.
Yeah.
That's what you do. Be the best. You got to beat the best, and you got to train like the best. So this is a marathon. This is not a sprint, but there are splints along the way. There's highs, there's lows, there's hills, there's valleys. You're asking great questions. It means you're really thinking about this, and I love it. You have the best audience in the world. Yeah. Okay, so yes, you leave the hospital. You have a prescription for pain medication. We very quickly try to get you off the narcotics. We use Tylenol as our mainstay because in theory, an anti-inflammatory like ibuprofen or Motrin or Aleve, in theory, slows down bone healing. In theory, it acts as a blood thinner, and we already have you on a blood thinner. So Tylenol is our mainstay. And hopefully you're off the pain medicines a week, 2 weeks. The more you stretch, the more you move. As soon as you can get into a swimming pool or get on a stationary bike, you get the lactic acid out, you get your muscles working, you get your head in a good space. So all of those things help. Pain is multimodal. Pain is here as much as it is at the site where you were injured. Buddhist monks, meditation, yoga, all of these things I'm a huge fan of. We've talked about this, and I don't want to get too into the weeds about legality or moral things. If you have access to the chewies or the gummies, the THC, the CBD, whatever these things are, don't inhale them because the lung damage is terrible. But if it's legal and safe, I don't mind, because those are a nice adjunct to treating pain. So in some states that's legal, and some it's not. But it's helpful. It's one more thing. Pain is multimodal. Being psychologically prepared and strong is your best defense against pain more than anything.
Absolutely. Absolutely. I feel like patients, like you said, who work out or do some sort of physical activity, they're way better, more tolerant for this process. So
I agree with you.
All right. This next one is about the nail removal process. Is it really serious? And when can patients expect to walk normal after removal? And when can they expect to train normally again?
So everything's potentially serious. The complications of anesthesia itself. You can cause damage removing hardware. Screwdrivers can slip, an incision can be in the wrong place. You know, any surgery has inherent risks. So you go to someone who has good experience. I and particularly one of my PAs may have the most experience removing precise rods of anybody on the planet. And I don't say that lightly, because Dr. Paley's been doing this a lot longer than me, but I take out most of the hardware. Mm-hmm. Not as a shout out to me or how great I am. That's what I'm getting at. What I'm getting at is that I take out a lot of hardware, which means I have a lot of experience. You can get into a lot of trouble taking out hardware. And the general orthopedic realm, the mantra is nobody looks good taking out hardware. It is much easier to drill a hole and screw a screw in, because you are exerting pressure while you turn. What happens if, as you try to remove it, the screw strips? Or there's bone overgrowth in the screw edge, or the screwdriver is whatever. There's 1,000 things that can go wrong. So it's not necessarily that it's serious, but and let me rephrase that. There are potential problems, pitfalls, complications along the way. You want to have someone remove your hardware, ideally the person who put it in, because they're familiar with it, the exact screwdrivers, the nuances of the screw head, the screw sizes. They know where the incisions are, where the nerves are. But fine, let's assume your surgeon's experienced putting in and taking out. In general, it's an outpatient procedure. I can't think of the last one that wasn't. Even femurs, tibias, and fibulas, all hardware above and below the knee comes out at the same time. Let me close this door.
Oh yeah, you sure?
Marshall, go.
Marshall.
And we'll put numbing medicine around the surgical sites. Some people may get some pain pills for a few days. You can walk, you can get on a plane, you can go up and down stairs, you can ride a bike. Depending on how many screws, where the screws are, how your bone is, what your activity level is, where you're going, where you live, all these things. Global statement is, for about 2 months, I keep you from at-risk activities. Downhill skiing, kickboxing, heavy squatting, anything with cleats where you're pivoting. You can go for a jog on a treadmill. You can ride your bike. You can get in a pool in a week or 10 days when your incisions are healed. But your bones have had rods in them for a year and a half, and they have been sharing the load. So your bones have not had to carry 100% of the weight put on them, because the rod and screws are carrying some of that weight. So once the rod and screws come out, your bone is now like, oh my gosh, wait a minute. I'm suddenly getting much more stress than I had, and you get additional bone healing. So this is kind of back to that earlier question about bone diameter and this and that, and personal experience. Yes, bones can get thicker. In general, not a lot more. But we've had patients where we've done lengthening, the rods came out, and then years later they have lengthening again or some other surgery, and you go to hollow the canal, and there's bone in there where there wasn't when you took the rod out before. So yes, bone does grow back. It may not necessarily get that much wider, because it doesn't in general once you stop growing. But yeah, so hardware comes out in 1 day. If you're international, maybe you stay a day or two for anesthesia, make sure the incisions look good. Back to training normally. I mean, if you're doing crazy stuff like 500-pound squats, I might say 3 months. But general stuff, 2 months, getting back to your normal. If you're continuing to improve in your function, your flexibility, your endurance, even if it's a year and you're continuing to improve, I would not yet take the hardware out. Get to maximum improvement, because what if you only get 80 or 90% back and one of your hips is just a little tighter? You've tried therapy, you've tried stretching, you just can't work it out. maybe that's an opportunity when we're taking the rod out, we could do a tissue release if you need it. Not often that happens at all, but if you came 6 months after lengthening, there's no way you're recovered, and it would be a waste of an opportunity that maybe you need something else later down the line.
I never heard of that. That's super.
You know, last thing while we're talking about is scars. People get very, very hot on scars and what to do. First, second, and third is keep it out of the sun. Cover it with a mechanical barrier, a bandage, or thick clothes. Put sunscreen on it after it's healed. Don't do fancy stuff that costs a lot of money, because we may use those same scars to take the hardware out. So talk with your surgeon. Which scars might you touch again? Which ones might you not? If you're going to spend thousands of dollars on laser treatment and we're going to go right through that same scar again, that's money better spent. So
those are some unique tips. You don't hear about that. That's huge. Yeah, for the removal process.
We can do a whole thing on hardware removal, and I can try to drum up some pictures.
Yeah, that would be great. I think we got to do that for the next one, because there's not a whole lot of like information on that. I mean, because everyone just goes their own way, you know. So that'd be great.
I can show you pitfalls and perils. I can't give away all my tricks because I spent a lot of time learning how to do this very well. I'm not going to give up all the goods.
No way. You shouldn't.
Did I ever tell you this story? And if I told you, it'd stop me, about Picasso and the drawing. So I don't even remember which book I was reading. So the story is, this woman is in a cafe and she sees Pablo Picasso sitting next to her, and he draws a scribble drawing on a napkin. And he's getting up to leave, and he crumples it up. And she said, "Oh my gosh, Mr. Picasso, I'm such a fan. I would love to buy that scribble you just did from you." And he said, "Yeah, of course, $20,000. And she says, $20,000? It just took you 2 minutes to do." And he said, "No, young lady, it took me 60 years to do that drawing." I was like,
I love it.
I used to, I don't know, feel bad is the right thing. Sometimes people come to me, well, now it's more than it was when I was younger, but I instantly know what to do, right? This is the problem, and this is a solution. I have the experience, I have the expertise, I have the confidence. I know this is what the solution is. When you're first out of training, it's not always like that. No. And then I think, gosh, it took me 4 minutes to come up with a plan for that person, where before maybe it was this or that or agonizing. That's experience. That's what you're getting. And it's not me. I'm one of a whole team at the Institute, but that's what you get with the experience. That's what you're paying for. And not to make it a financial conversation, but we say you get what you pay for. And there are places who may offer it for cheaper or different structures. What are you getting for that? So absolutely. Anyway.
Absolutely. I think the experience matters. I get off topic. No. You're doing fantastic. All right. So this next question is about like how you evaluate whether bones are full weight bearing or not. Also, are AP or anterior posterior views sufficient, or do you need both lateral views as well?
Nope. So there's a lot of shout outs today. And I've said this to you before. I'm pretty smart. I think I can hold my own. But there are certain things I'm good at and certain things I'm not. And if someone teaches me something, I don't take credit for it, or I don't try to. I try to always give credit to the person who taught me that. So my first business partner, my first practice partner, was this amazing man. He still is an amazing man. And I won't say his name because I never asked if I could talk about him, but his first junior partner. So he was in practice. He had a guy who came, and that guy left, and then I came. Had a quote: "One view is no view." One view is no view. You always need two views orthogonal to each other, 90 degrees to each other. So a front view and a side view. So one view is nonsense. No one can make. Now, if you had a previous x-ray showing full healing on the lateral and the AP was deficient, then maybe you don't need another lateral to say there's healing, but that I'm getting into minutia. One x-ray is not sufficient. A lot of time our patients will send an x-ray from wherever they're from, and it's just a full-length standing x-ray. It's low resolution. It's a JPEG image. It's not a DICOM. I say, this is great. You know, your length looks fine. I don't see anything obviously broken, but I can't assess your bones. So no, you need two views. Full weight bearing is fluid. In general, we're getting x-rays on 1 month intervals. So maybe you are ready at 9.5 weeks, but I'm not seeing it 9 weeks. I'm seeing it 8 and 12. So it depends on what your activity level is. It depends on what nail you have. It depends on how much you bone have front, back, and the sides. There's some fluidity to it. I am more not cautious is a wrong word, conservative than other people may be. it's better to be on crutches or a walker a week too long than a day too short. That being said, maybe it's happened, and someone can chime in if I'm wrong. I can't think of anyone who's broken their nail in the consolidation period following our orders. I'm sure it's happened. You take a harder step than you think, you slip getting off the bus, the crutch slips. It's usually the result of a trauma and a shock load that's more than you intended. I can't think of anyone who's had a fracture because they were walking with 68 pounds and I told them 67, or, you know, I'm making up numbers there. So there are occasionally patients who have such good bone that it's not just walker to nothing, that I do transition from walker to crutches, but it's a case-by-case basis. And if any of my patients are on, they can affirm this.
They are
say it.
actually. So one of them, well, they're not on this, but somebody, one of your patients sent this in today. He's actually one of your patients. And you can use this as an example.
Looks about 4 weeks. I was going to say that looks to me about 4 weeks since the end of lengthening. I'm just making that up. What is it?
That is exactly like. Well, I think he finished late August, so like about 8 weeks. But he's
so 6 weeks. Okay, but I'm not going to get on the side views. Yeah, so interesting. Look how that person has more healing. Good. So that's a side view, probably of the right side view. Look how the left side has more bone in the front and more bone on the outside than it does in the back, and it does in the other leg. Same surgery, same surgeon, same person. Why is there more bone on one side than the other? It makes no sense. And that's why we get x-rays routinely and we check them. And I say to my patients all the time, I'm having this conversation with you. What I say next door, what I just said next door, doesn't matter. I'll worry about them later. I'm worried about you right now. And this is what I'm telling you. And so you telling them what I said to you doesn't help anybody. It confuses things. So I'm managing your care right now. And you're the most important person in the world right now. So great. The person before you walked at 8 weeks or 12 or 14, I don't care. I care about you. And I'm going to give you my full attention, and I'm going to make the best decision to help you reach your goals and help you to recover. Because I do this a lot. I do this every day.
So individualistic. Yeah. But how? Yeah.
So this patient is still, those look like 50-pound nails. This patient is still 50 pounds. In a couple weeks, they may be able to switch to crutches, because with crutches, there's no way to fully unweight, but with a walker, there is.
Okay.
So no, this person's staying on a walker.
Oh, wow.
And there's still, there are some people who are more conservative than, or less conservative than me, and they'll let them start walking now. But I tell my people it's going to be between 2 and 3 months, usually 3 months. Maybe it's less.
Yeah. Yeah. No, that's fair.
As I get older, though, I am telling people not to wait a month to send me x-rays. Send me again in 3 weeks. Because I do appreciate, I know my 2-second analysis and a quick answer by email is nice for me, and I'm on to the next thing. I've given you my full attention. I made my decision, and I move on. But I understand there's a human being on the other end whose life is affected by that answer. Oh my gosh, crutches another month. I'm going on this trip. I have the kids. There's daycare. My job. I am fully conscious of that. I don't just say things, to check things off. I really give it my full attention, and I know there are consequences. Slowing down means longer to get there. Slowing down means staying longer in West Palm Beach if you want. Slowing down means more hotel, more food, more money. The people at home are waiting for you to get back work. I don't make these decisions in a vacuum. I consider all of these things. Anyway, so, okay, I don't remember what the question was anymore.
No. It's all about like full weight bearing. But you know what? Safe is better than sorry. So I think that goes a long way. All right. So a couple more questions here. Then we'll take some in the chat, and then we'll do the outro. This is a big show. You're first coming back. So let's see. How are reosteotomies done in surgery without breaking the nail?
Great question. That's a great question. All right. So assume the bone is round, and assume the bone is in the middle. If I make an incision from the front, I can cut the front of the bone, the inside of the bone, the outside of the bone, but I can't get through the nail to the back. So now I make an incision from the side. I can get to the back now, and I can get to the outside again, and I can get to the front again. So 2 incisions, one from the front and one from the back, and you can get all 4 cortices. So that's how you do it. It's tricky. There's nerves. It's different incisions. What we do is pretty amazing. Through little 1 centimeter incisions, we're breaking bones. There are tricks to it, but that's generally how you do it. We joke, and sometimes for various situations, it might even be faster and easier to take the whole nail out, break the bone with nothing in the way, and put it back in. But that's how we do it. So it takes 2 incisions to break the bone. Every now and then, it just breaks in such a way that you hit the bone perfectly, and it actually completes the break through just 1 incision. It's not often, but that does happen.
It's like hitting a football and like perfectly.
Yeah, perfect break. Exactly.
That's crazy.
Yeah.
All right. This next one here is: do you prefer peroneal nerve decompression only for quadrilateral patients, or also for tibia patients on their own?
Not tibia patients on their own. Dr. Paley found over decades that in general, the patients who are doing quadrilateral seem to have less pain doing the nerve decompression prophylactically. So instead of having the incision in the middle of your leg, like you're having tibia only, we move that same incision up by the peroneal nerve, and we do the peroneal nerve, and we cut the fibula bone through the same incision. So so quadrilateral.
Okay, so very efficient. All right. Can you explain how bow leg correction can be done in a tibial lengthening surgery?
So assuming your bow leg is coming from the tibia, which it usually is, we're going to cut the bone to put to get lengthening. So why don't we cut the bone, make it straight, and then put the rod in? So sometimes it's much more complicated than that, where we actually, of course, before surgery, and we can show you how we do this, we draw the lines, we know where to make the osteotomy. And these are all the osteotomy rules that Dr. Paley wrote about in his world famous book on limb deformity correction. But we follow the rules, we figure out where we're going to do our osteotomy. And sometimes we'll actually temporarily attach an external fixator. We'll put pins in the bone above and below, sometimes 2 pins from the front, 2 from the side. We break the bone, we manipulate the bone into the new position, and then the nail goes down. In general, there will be extra screws put because there are screws that hold the nail to the bone, but then sometimes we put screws on either side of the nail. If I cut the bone in a place that's very wide and the rod fits in the middle, in theory, the bone can move around the rod. So sometimes we'll actually put screws between the bone and the rod, and they lock the nail in place, not necessarily through the rod itself. So yes, we can correct deformities concurrent with lengthening. The most typical one we do is bow leg, and it's most typically with the tibia.
Wow, that's cool.
So it adds time. It may add hardware. It makes the surgery longer. It may add a few extra scars. There is an extra cost for that. Sometimes there's nerve decompressions or fasciotomies or other things done with it. But yes, that's a very general explanation of how we do it.
And it might add a little bit extra height. So
that leads into number 15.
Yeah.
Some people get 2, some people get 1, some people get 3. Anytime we're worried that the bone may shift in position or we want to prevent the bone from shifting, we'll put screws to block that space. So we call them blocking screws. The real name is called a polar screw, I think capital P-O-L-L-A-R, and it was described by a traumatologist, and the people who trained me are embarrassed I don't remember, but we call them blocking screws. And that's typically in the tibia, not very often in the femur at all.
Got it. All right. And this last one, if Aaron did cosmetic limb lengthening, he was 5'9".
I wouldn't. And again, a personal story. When my daughter fractured, dislocated her elbow, I called my partner, and my partner fixed her. Could I have? Technically, yeah. But you know what? I'd rather be the dad and not the doctor.
Got it. Very cool. That's awesome. Would you let him do it though?
Yeah. Oh, that's a different question. Okay, fine. So if my child wanted limb lengthening, would I let them do it? Well, all my children now well, Oliver isn't 21 yet. They're older than 18 now. They're old enough to make their own decisions. I've had this conversation 40,000 times already. Wow. It's not a simple, no, not with my kids. I've had conversations with parents, and families and kids 40,000 times almost. It's a hard decision. I have families that are very articulate and are very good at expressing, I don't support the decision whoever made, whether it's my spouse or my child, but I support them. And I wouldn't make that decision for myself, but it's a decision they made. I may or may not understand their incentive, but I support them. And that's what we all want. It's nice if you agree with me in a way that you would do it too or not, but that's what we're getting for, because regardless of the reason, and again, we're getting off topic, but you and I have had that conversation. Who's the candidate for this? These are the people in general who are really affected by their height. Call it dysphoria, call it whatever you're going to call it, but it's people who are concerned about their height. And I'll just kind of leave it at that. Is it 10 hours a day? Is it 4 hours a day? Is it wearing lifts? Is it not going out? Yeah, there's a very wide spectrum. And I'm probably more conservative about it than I know you've had Marie Gadalovich on it. Mm-hmm. And she's awesome when she talks about this. Her sister, you know this, her twin sister is a plastic surgeon. Mm-hmm. And Marie will show breast augmentation and stature lengthening. Why do we hold stature people to a higher standard? Why do you have to justify your reason to have it when anybody could go get a breast augmentation? You know, it seems like a double standard. And I think she's right. You know, there's nuance to it, but if this affected my child in such a manner, then yes. And this was the best decision for them, then yeah, I would be hypocritical if I said no. So I'm not saying yes, just because I do it. We've said this many times. I take this very seriously. People might say, oh, it's just a stature surgery. It's not a limb reconstruction. You help kids walk. You help people with infections. And yeah, that's all true. And that's great and wonderful. But people want to be taller. And I think I'm providing a service, and I think I do a good job. And I think my heart is in it, which I think is really important. And I take it very, very seriously. There is no such thing as, oh, I'm just going to go do a stature surgery today. You can have terrible problems in the simplest surgery, taking out a screw, hit an artery, who knows what terrible things can happen. So I take it very, very seriously. Yes, if my child wanted it and we had all the conversations and I thought that they were intellectually capable of making this decision, they were emotionally stable and truly understood the ramifications. Yeah. What if they were 17? What if they are 16? That's a much harder conversation. And I'm starting it, and I don't know what the answer is, because then it's parents trying to make the best decision for their child, because they're the ones legally making the decision. We haven't had somebody come in where the parents are dragging the kid in saying, we're doing stature lengthening even though you don't want it. That doesn't happen. That you know, maybe that happens on TV, not for this, but for other things, but that doesn't happen. We're not doing that. We're not, two parents want their kids taller, so we're going to strap them down against their will because the law says we can't. No, that's not. This is a really serious thing. And in general, you know, you do this every day. You talk to patients about this, and you're in this world. Most people don't just flippantly say, hey, today I want to be taller, especially children or young people. It is a family decision. There's a lot of money involved. There's a lot of time involved. There's a lot of angst involved. There's sometimes one caregiver, going to the question about if it were my kids. Generally, one caregiver is with the child in a different state. The other caregiver is home. Maybe there's other children. That's loss of income. That's loss of time. I mean, there are huge ramifications from this, in addition to the psychological angst that may be causing the child also. So anyway, great question. Lots to unpack there. But yes, if we check all the boxes, yes, I would support my children, and no, I would not do the surgery.
That is phenomenal. That's a phenomenal answer. Wow, that is huge. I could make a whole video out of that. We could do a whole chat on that. That's so great. All right, guys. So now we're gonna go into the live chat, and then we'll do that for like 10 minutes, and then we'll find out what Dr. Robbins has been reading or listening to lately.
Oh yeah,
and what he's cooking, and then we'll set up for the next one. All right.
So and then Victor and I are picking a day where I interview him.
Yeah, exactly. So you guys can know more about me. Yeah,
we're both Walmart. Yes,
I'm done my training for the year. So, okay. So yeah. So hey, Dr. Robbins, good to see you. Nice beard. They love the beard. All right.
Rachel's moaning. Let me open the door. 1 second.
Yeah, sure. Go ahead. All right, guys. So jam your questions in there. We're gonna do these kind of like fast, rapid fire because we've been on for over an hour now. So let's see here. So this question was about embolism. I think you kind of answered this earlier. He says, can you get a brain damage from an embolism? One patient unfortunately went to a coma after surviving embolism in Europe. So I'm kind of curious how this can happen.
Well, so let's just step back. Are we talking about a pulmonary embolism that then goes to the lungs? Or maybe they had a heart defect and then it went to the brain, or maybe they had hypoxia because their lungs were so affected. There's a lot of terrible things that can happen. Yes, a blood clot in the leg called a deep venous thrombosis can dislodge, and if it's big, it can block the lungs. And if it blocks the lungs, it blocks oxygen. If it blocks oxygen, it can cause brain damage. That's like the terrible cascade. as opposed to if it's fat embolism, or it's not a blood clot blocking the lung, it's the fat overwhelming the lungs and your body having an inflammatory response, and you can get hypoxia and organ failure. So yes, these are not to be taken lightly. This is highlighting the point. Bad things happen from any surgery, whether it's elective or post-traumatic or cancer, or you need to have it because you have the heart valve replaced. There are risks. If you don't have surgery, you can't have surgical risks. There are risks. They're rare, and you want to make sure your surgeon knows how to treat and prevent and recognize the surgical risks. But yeah, patient get blood clots, recognizing them and treating them, it's scary. Absolutely. So how it can happen, I don't know why they got the blood clot, but what can you do to help yourself? Wear your compression socks, get up and move, pump your calves, get on a stationary bike, get in a swimming pool, keep moving. And that's not just post-surgical, that's in general, that's life.
Yeah, absolutely. Absolutely. So this question is, how successful would Paley Institute quadrilateral, not a rebreak, limb lengthening be for me? I'm a healthy 19-year-old male that stretches daily for months beforehand. Can 4 inches be guaranteed?
No.
That was the one word.
How about is 4 inches possible? Yes.
There you go.
Never. I've said this before, I won't name them. I can think of readily more than a handful of patients doing quadrilateral who are barely getting to 8 or 8.5 centimeters. I can think of a few who are getting 10 to 11. You know, the average is 9 to 10 in general. 10 we say is realistic. It is realistic. Is it guaranteed? No. Are you going to work hard? You're great. You're wonderful before, but if you slack off when you wake up, then you're not so wonderful anymore. So no, nothing is guaranteed. And if someone guarantees it for you, please look elsewhere.
There you go. That's right. Look at that. They love it. Dig the beard, man. It might be your new thing, man.
No.
Keep it for Halloween. Keep it for we're going to talk about your costume later. So from Dashley Productions, to gain 3 inches with optimal long-term athletic recovery, would it be better to split up the 3 inches between the tibias and the femurs as opposed to just 3 inches on the femur alone if money was not a concern?
Right. So okay, fine. Money is not a concern. 60% or 65% or 70% of what we do is femur only. Very small amount, 5% or less probably is tibia only. The rest is quadrilateral. I'm sure there have been tibia lengthenings without deformity correction and without quadrilateral, but there's not a lot of them. Look, if you have femur lengthening, and we're not getting into a discussion about proportions and arm length and all that stuff, but in general, 99.9% of people who come to us for stature lengthening are normal proportioned human beings. They're not as tall as they want to be, but they're normally proportioned. The tibias are 80% of the femur plus or minus. Their legs are 52% of their height plus or minus. And you change a number, you change a ratio. What does it mean functionally? It means when you are seated and your legs are parallel with the floor and you lengthen your femur, you will lean forward more to rise. You have to move your center of gravity forward to get up to stand. If you are a deep, heavy squatter, your deep, heavy squat will probably go down. You may have to squat back because otherwise you're going to be very tilted forward. So that is a true functional thing. The interesting thing is we have cyclists, road and mountain, which means you're clipped in or not, or different types of clips, who can ride a bike, which is intuitively, I would think it wouldn't work, but they do. There are runners, there's water skiers, there's downhill skiers, rock climbers, and they're getting back to their sport. So, you know, what's your sport? What do you do? So that's sort of the soft, long-winded answer, but here's the rest of the answer. Let's say whatever your activity level is when you're 19 may not be when you're 20, when you're 30, when you're 40. Let's say you do surgery now and you decide for cost, for time, for risk, you do 6.5 centimeters in the femur. So that's 2.5 inches. Oh my gosh, it's the most amazing thing in the world. And you happen to find some sport or activity where just the actual numerical disproportion is causing a functional problem. Okay, well, you said money is not a concern. Then take the 6 months off, do your tibias for that, whatever makes your ratios back to want them to be, and then there shouldn't be any problems. So we're not having patients reporting problems. Dr. Paley's been doing this for almost 40 years now, 38, 39 years, and he's not having people call up decades later and say, guess what, I can't do X, Y, Z. Mm-hmm. And the last way I'll answer the question, this guy, you know, if he's coming on the young end, I'm 19, 20 years old. I've told this story before. I think it's a great story, and it's not apocryphal. It's an actual story. An older guy, probably now my age, 50 something years old. Hey, I'm not running my 5Ks as fast as I did before surgery. And I said, well, you took the year off to kind of recover from this. You were a pretty good runner, which means you haven't trained. All of your peers have sped up. Your body's changed over 2 years. You know, how much slower are you? I don't know, 10% slower, but I'll always be taller. And one day I'll stop running. And that was a really mature response, right? You had your days where you could squat 600 pounds. You don't need to squat 600 pounds anymore to do your bodybuilding stuff. Fine, you don't do 600 pounds, you do 500, 400, you know, whatever it is. So easy for me in my 50s to say, oh, 19 years old, what do you know? But I don't think it makes a difference. But if it does, you can always have the tibias done. You said money's not a concern. Come have your tibias, get the ratios where you want them aesthetically, functionally, whatever it is. And happy to help you develop a life plan to make you happy and reach your goals. I
love that, because you're right. I think athleticism and, you know, physical fitness is always a fleeting attribute, right? Like, and whenever you get lengthening and it takes you 2 full years or however long to get back to full recovery, you're now 2 years removed from that point where you were in time. And that has happened to me, like you said, in bodybuilding 10 years ago.
What was yours? What was your recovery? You've said 2 years, right?
Yeah, it was 2 years for me. And I was able to pull 600 pounds then from the floor. I couldn't even imagine picking that up now. Like I snapped my spine in half. So I love that you said that, because it's so true. I go into the gym now and I'm like looking at the younger guys.
Pardon me one second.
Yeah, sure. Yeah. All right, guys. So let me see. Let me find the next question. We're doing Darren's. Okay. So a couple more questions, guys.
Okay, ready.
Yeah. Okay. So this one from Darren, he's saying, how realistic is it to only use a walker and no wheelchair with precise 2 nail? Is it just an impossible way to live during limb lengthening? Also, can you use the stationary bike on the lowest setting as much as you want?
Yeah, so it is realistic. It just takes longer. Like, don't be a hero. You could spend 20 minutes walking down a long hallway to get to the mall or get to the clinic, or you can jump in a wheelchair and do it quick, and you spend 5 minutes in the wheelchair and then you get up and walk. So yeah, you could. Is it realistic? I don't think anybody does. Don't be a hero. If you can use the wheelchair, use it for convenience. Stationary bike is great, but stationary bike, your hips are flexed and your knees are flexed. What are you getting from it? It does help with strength. It does help with endurance. It does help with getting your heart rate up, lactic acid and all that. But walking or running in a pool is much better, because then you are standing up, your hips are extended, you can fully straighten your knees. So stationary bike is great, but that's not the end all be all. That is just one tool in the arsenal. Get up and move.
Marshall, he's like, I'm hungry. All right, we're gonna speed through this.
No, I fed him. He wants to go to the bathroom. He's like,
I gotta take him to the bathroom.
No, it's a long walk. It's a whole to deal with him.
Okay, all right, we're gonna cap it in like 10 minutes. I promise. Marshall, hold on. All right, 10 minutes countdown, guys. What is a hamstring recession?
So if you get a turkey leg and you see all the muscle meat on one end, and then there's like the white stuff, and then the tendons on the other end, where the tendon and the muscle kind of overlap, there's the white layer of tissue, and we loosen the layer of tissue. We don't loosen the muscle. So it just gives the muscle a little more excursion.
Got it.
It's in the area where we're doing the IT band release. It may help with knee flexibility. So we do it. Doesn't cause any weakness. It's much different than doing like an Achilles tenotomy. Achilles tenotomy, which some people do for equinus ballerina foot after tibia lengthening too much, that's terrible. You're cutting tendon, you're changing tendon muscle ratio, you get permanent weakness. This is not that. This doesn't cut the muscle at all. It loosens the sheath around the muscle and it grows back, just like the IT band.
Oh, very cool. Awesome. Typically for proportions, how much should your final height be taller than your wingspan? This is a proportion question. I don't know.
Yeah, I mean, I don't know. How did you start? Some people have a longer wingspan than height, then it gets less. If you have a shorter wingspan, it gets more. That's part of the aesthetics, man. You're going to look in the mirror every day and decide, how do you look? Your height is one thing, but if the aesthetics aren't making you happy, then you stop.
Okay.
Every day is a decision to stop.
So John's asking about the 3D shape of like the bone, and so how can an AP and lateral X-ray be sufficient to understand the right nail to use? X-ray is just a shadow, so don't you need a CT scan to be more accurate?
when you go to school as long as I have, and you've done this as long as I have in general, and I don't mean that to be condescending. Assuming you're coming in with a normal bone and you haven't had trauma and you have a normal shaped bone, this is what I do, man. I assess you. I do not need a CAT scan to make the assessment. And again, I have all the nails. I have the nail sizes. If you're better for a larger nail, then I'll use a larger nail. If you're better for a smaller nail, use a smaller nail. But I'm pretty good at guesstimating what nail's gonna work.
All right.
So no, you don't need more radiation.
More radiation. All right, a couple more questions here. Let's see, I'm trying to find the good ones. Let's see. So my bones were over-reamed, and then a trauma nail was put in to help me weight bear. Is it okay to leave the trauma nails in my legs now because I'm afraid of a refracture?
Yeah, the trauma nails are designed for life. They never have to come out. If the bone initially heals a lot and then it doesn't do the final healing, you can take the screws out and leave the nail in the canal.
Got it. All right. This one's about I want to join the Air Force. I will wait 3 years after leg lengthening. Do you know any military rejects, people like me?
I don't know what questions they ask. I have no experience with this. We have done lengthening on people who have joined the military. Maybe some of those have been bilateral, obviously reconstructive. I don't know the answer to that. The interesting thing is, depending on what you're going to do, I know that I know. Somebody knows more than me. There are probably height cutoffs to be in a submarine or be in a fighter pilot cockpit or be whatever. And those are probably made on anthropomorphic data, meaning if you are 6 feet tall and you follow the normal patterns of proportions, which most people do, your legs are a certain amount, your femurs are a certain amount. If you lengthen your femurs 3 inches, then in theory, your body would be 3 inches taller. Sorry, if you lengthen your femurs 3 inches, your tibias would proportionally be about 2 and something inches longer to be proportional. So that's 5 inches. So your torso would proportionally be another 5 inches. So a 3 centimeter lengthening is as if you were a 10-inch taller person proportionally. So that means you may not fit in the fighter cockpit. Maybe you went from 5'7" to 5'10", and a 5'10" person would fit, but you now have the femur disproportion of someone who's like 6'7". So I don't know. That's an interesting question. I don't know. I would ask the military what their current regulations are now before you do it, and then you get banned. Marshall, stop.
Absolutely. Yeah, Marshall, we're only got 3 more questions, and we're gonna wrap up. So here we go. This question here is, hi, Dr. Robbins. Would you do leg lengthening on a 6'6" patient to achieve a dream height of 6'9"? Wow. Dream height.
That's
wow.
tough.
Yeah.
Dror says he's told this story publicly many times. Long time ago, a patient from Scandinavia was whatever the height was, 6'1", 6'2", 6'4". I'm bothered by my height. All my friends are taller than me. I'm the shortest person I know. All the things that people say, and Dror turned him down. And then he realized, after doing this for decades and decades, that guy was just affected. His starting height is different. I guess so. I don't know, man. It hasn't happened. Pardon me. One second.
Absolutely. Yep. All right, guys. We're gonna just answer these last couple questions. This one's from Douglas. All right, we'll probably end on your question, John. John just put in a last question. So we'll do last couple questions here, and then we got to wrap because he's got to go take his dog out, and I do too, actually. Alrighty. So you guys liking the stream? Dr. Robbins? Show him your love in this chat. Say thank you. Comment below. Make sure to give it a like. Share it to all over the YouTube algorithm.
Hey, Victor. Can you hear me?
Yeah, I can hear you. What's up, Master Broken Legs? 6 broken bones.
I had surgery on Monday.
Yeah, I know, man. That's crazy. That's crazy, brother. We should definitely talk about that for sure. If you can come on next week. I think we're gonna do like a patient update next week, and then sometime in early November we're gonna do another surgeon thing. So, but
Okay.
I'm just gonna wrap up this one.
Just saying hi to Dr. Robbins.
Yeah, sure.
Well, I've asked him a question about pain meds, but I think he already answered it.
Yeah, I mean, this guy's been going straight for an hour and a half,
Yeah.
like cranking him out. Like he's a machine. I couldn't do it. I mean, he's a beast. Victor and Robbins, you both are amazing. Really appreciate the time. No, thank you. Thank you, John, for your questions. I really do. Darren, thank you. Very informative. Thank you. Like, I'm going to let Dr. Robbins see all this when he comes back on because this means a lot to him. He really likes the... Is that a big social media guy? I have to pull him out.
Back.
Dr. Robbins, they're loving the episode. They're saying, thank you.
All is well.
Yeah. Okay. So here's the other question.
Wait. Did I mute you? Hold on.
Oh, yeah, maybe you did.
Okay, I'm back. Sorry.
Okay. So this question from Douglas, he's saying, if I have occasional nerve pain in my thigh about an inch above my knee that pops up occasionally and goes away after about a minute of walking, would this be a problem for femur lengthening? You might have asked.
That's weird. You know, again, we don't know, was he a football player and he has impaction in his spine and he's got stenosis? I don't know. Any problem you have, lengthening will exploit. So I would try to dive in and figure out what it is before, because maybe it's something preventable, or maybe I just say you have an increased risk of nerve irritation causing a problem, and maybe your goal of 8 centimeters isn't as realistic as 6 or 5 centimeters. And I'm just making up numbers here. I don't know.
Gotcha.
But yes, any problem you have will be exploited, and problems you didn't know you have will be exploited as well. Lengthening is not to be taken lightly. It is a big deal. It is a big deal. Some people skate through it with very few problems. Some people don't.
Yeah. Yeah. The majority probably don't.
Right.
So this one, can you do quadrilateral at the same time as if you do conservative lengthening?
So I think what he's asking, can you do all 4? So when we say quadrilateral, we mean tibias, then femurs 3 weeks later. Yeah. We don't hollow 4 bones simultaneously. That's dangerous. So no, the quadrilateral spread apart by 3 weeks has nothing to do with being conservative with lengthening. It has to do with the safety of the surgery itself. So yes, quadrilateral to us means tibias first, femurs 3 weeks later. I know, Marshall.
All right, you guys. All right, we actually have one of your patients on the panel here, Aaron.
Okay. Hey, am I seeing you tomorrow?
Oh,
can't hear you.
Can't. He always has the best audio in the world. So I'm just kidding. He's gonna come back. It'll work. But let's answer this one. Any news on the PMAX? We probably know the answer. No. Okay. Here he is. Okay.
Can you hear me now?
Yeah.
Awesome. Yeah. So Dr. Robbins, I'm actually going in to get X-rays, but obviously after that, I'm just probably gonna leave because I don't want any extra charts just to see you. So you can just email me the feedback.
Are we not doing an interview tomorrow?
Oh, I mean, I've heard about that. I don't know if that was like set up yet, but I know there's supposed to be. There's a photographer that's supposed to come tomorrow and just shadow me around. So
he's like a celebrity now. He's done so
many. Whatever Angelique says.
Yeah,
we'll figure it out.
Yep. Sounds good.
But he's been a big help to the community. He's been like sharing a lot of X-rays and stuff. He's been helping people.
So have you been listening? Do I say anything different on here that I say to you or you've heard me say to anybody? Am I talking out of the side of my mouth about anything?
No, I think everything is kind of like what I expected from you already.
Okay, good. Look, it should be boring. Nobody who follows this should hear something today they never heard me say before, right? I mean, I may think of a different example or say something else, but 98% of what we talk about is written in the guidebook. There's no surprises here. There should be no, oh my gosh, nobody told me that. That'd be impossible, I think.
All right, last question, then we're going to just do our wrap up with Dr. Robbins here. So are most modern orthopedic nails removable by any orthopedic surgeon, even without the exact tools meant for that nail?
Yeah. So again, nobody looks good taking out hardware. Different countries have different hardware, and different hardware can look the same on X-ray. We've had more than a handful of people who have an X-ray from a different country, and it looks exactly like a certain product. We have everything for the certain product, and the screwdrivers don't fit. So it is so helpful to know where it was put in and what it is. So we dictate in all of our op reports, it was this brand, this size, and then it's easy to look online and find out what hardware you need to remove it. Now, that being said, there are plenty of companies who sell one-size-fits-all kits that have all different sizes, but if you don't have the right thing, you could really get into trouble. we have access to almost every removal device possible, and there are tricks. Sometimes, unfortunately, what happens is, and I can't think of the last time this happened, but let's say there's a screw and you don't have the right screwdriver and you've gone through all of them. It's some weird octagonal, I don't know, whatever. It just doesn't exist except in that place where it was put in. So instead of doing this to a little tiny incision, you may have to make a bigger incision, look at it with your eyeballs, remove bone around that screw and take a whole plug of bone out. Who knows? Sometimes you got to get the hardware out and you do heroic things. But yes, in general, any orthopedic surgeon can take out any hardware. The question is, do they want to? It's potentially risky. I don't say this lightly. You can cause more problems taking out something wrongly than putting it in.
Ooh.
So removal is not to be taken lightly.
Powerful. All right. So Dr. Robbins, what have you been up to? What have you been reading lately? Let's go through that. I'm looking at my list now. Gosh, since I talked to you, I probably read 40 books. Oh my God. So the reason Victor and I had such a hiatus was I was studying for my 10-year board recertification. Yeah. I went to Poland at the Paley Institute, Europe. I went to Abu Dhabi with the team to Paley Institute there. We may have done 11 stature patient surgeries there. Wow. Now I've seen them with my own eyes. Like, you're getting the same care in the other centers as you are with us. The surgeons there are excellent. The team is excellent. The facilities are excellent. Everyone's approachable. They're great. Okay, so there's a physicist who has passed a while ago named Richard Feynman. People my age and older may remember Richard Feynman because he was instrumental in talking about the Challenger accident. The Challenger accident was in 1986 when the Challenger blew up, and they found one of the many problems was something called an O-ring. It's a little rubber ring that sealed parts of a rocket, and the O-ring eroded and the hot gases escaped and it made it blow up. So Richard Feynman, who's a physicist, while he was giving his press conference, took a little rubber O-ring, put it in a glass of ice water to make it cold. And at the end of his conference, he took it out and he cracked it. And he said, "You want to know what happened to the shuttle?" Yeah, anyway, so he's written a lot of books. He was a really interesting guy. He won a Nobel Prize, but he wrote a book I read called The Character of Physical Law. It's basically him talking about, if you know anything about math or physics or natural science, it's really interesting how you can kind of sum up the working of the universe with just a few equations and what they actually mean. And it's like a lay person's guide to the world. I don't know. It's cool. That's awesome.
There's an author, a guy named Herman Wouk, W-U-K. If you ever watched the movie, and most of your parents have heard of the Caine Mutiny or the Caine Mutiny trial, he wrote a lot of big novels about World War II. He identifies himself as a very devout religious person. He happens to be Jewish, but he's also very articulate in all sorts of ways. And so he wrote a really interesting book called The Language God Talks. And what he means is mathematics. And one of the people he spoke to writing this book was Richard Feynman, among lots of other mathematicians. So he had exposure to Einstein, this guy. So it's an interesting way about how mathematics helps shape the world. Anyway, that was cool. Then I do a lot of sci-fi. So a book called Alien Clay by Adrian Tchaikovsky, a book about conversations with Isaac Newton. I just read The Odyssey again because, you know, the movie's coming out next year.
Yeah,
Christopher Nolan. So I read The Odyssey again. There's a guy named Bill Bryson who's like a tongue-in-cheek writer. He wrote a book about the human body for lay people, about English language, about walking the Appalachian Trail. Oh gosh, I read a book about Shakespeare. I read a Michael Crichton book about a volcano. I read Talking to Strangers, Malcolm Gladwell, just how people passing on the street, you don't know somebody's story. And if you can interpret and understand other people. Anyway, that's like some of the books I've read.
That's incredible. I love it. Like so philosophical, yet so busy at the same time. And all right, so what's cooking, Dr. Robbins? You got that big Halloween
party. Currently, right now, So right now I have 20 pounds of pork shoulder that I did a 7-hour smoke overnight. And then in the morning when I woke up for conference, I put it, I dry rub it. It's on the smoker. Now I wrap it and put it in foil, and that's finishing in the oven. I have 6 rack of ribs that I make a dry rub. I smoke them for 3. Then I wrap them for 3. And then as soon as we get off, I have to take it out of the oven. I have to vacuum seal all of it and douse it in an ice bath because I have to chill it. So tomorrow I can finish it because the party's tomorrow. I can't have pork and the ribs all come off at the same time and be hot. So I figured out I cook it and then I vacuum seal it, douse it in ice water. And then tomorrow I'll bring it to temp in the sous vide, the pork. So 165 or whatever in the sous vide. And then the ribs, I just reheat on the grill to get the char.
Oh my gosh.
So
it's such a process, but
you're making me hungry too.
And Halloween, the favorite holiday of the year. What are you going to be? What's Holly going to be?
So I will be Neptune with my trident, and I'm going to extend my beard and have like sea creatures in it or shells or whatever. Holly made this, and I'll send you pictures. You can post them. Holly, for the last 3 months, handmade a seashell bustier, like glued each single shell, and she has this net sheath, and she has seashell shoes. When she walks Marshall at the beach, she collects shells. So there's shells all over her counter, and she's been hand creating this seashell thing.
Wow.
Yeah, so that's Holly.
Oh my gosh. You know that they have like these Instagram accounts that will feature you guys if you take a cool enough picture and you like post.
Oh,
like,
no.
I'll have to send you some of them.
I think we have 10 people coming in, a couple of people coming in from overseas to stay with us. Is like a big fun thing.
That's huge. Awesome. Well, guys, I really appreciate you guys joining this chat with Dr. Robbins. Dr. Robbins, thank you so much for coming on.
Nice to be back.
Answer these questions. And if you guys want to reach out to Dr. Robbins for a consultation, you can see his contact information here below in the ticker. You can go to his website. It's limblengthening.org, or you can email him. That's the inquiry at limblengthening.org. You probably get in touch with his patient coordinators, Angelique and Lena. Like I said, he comes on monthly to do these live Q&As for you guys. You can learn more about limb lengthening, stay safe, and learn from somebody experienced like him so you don't make mistakes and get butchered out there. Because like you said, it's very serious and you got to pay attention. So, thank you, Dr. Robbins.
All right, Victor and I will talk offline in the next 2 days. We'll pick the day when I interview him.
Yeah, absolutely. We'll do my interview. So
this will be gone. Maybe I'll pare it down. I don't know. We'll see.
Get rid of it. They love it. They love it. Look at that. Darren's like, I'm hungry now. Darren, we're flying to Dr. Robbins' house.
That's right. I was hooked when Rich Rotella ate those shrimp rolls that you made, Dr. Robbins.
When we were down there.
Because first we made lobster and then we ran out, so we did shrimp. Yeah, that's right. Oh, those were good too.
Absolutely. All right, so Robbins and Marshall. We'll see you guys next time. All right, guys. Aaron, Master Distractor.
Bye.